Okay, let me start by thanks the organizer for inviting me and give me the opportunity to present adoptive cell therapy, but in the context of transplantation. Just let me start, and this is a continuation of what John just presented, that I think we all agree that in the field of cancer, genetically modified effector T cells has been a huge success. In the field of autoimmunity and transplantation, we are hoping to achieve similar results in the sense that we are hoping to achieve a transplantation tolerance and to cure autoimmune disease. However, the type of cells, of T cells that we are going to use are regulatory T cells. And let me give you just a little background on these cells. These regulatory T cells are coming from the thymus. They are a small percentage, between 1 and 5% in the peripheral blood, as you can see here. And they express the CD25 molecule, that is interleukin-2 receptor alpha chain. And they also express the FOXP3, that is a transcription factor. But what is important is that these cells are key in maintaining peripheral tolerance and also are very important in preventing autoimmune reaction. And this has been demonstrated in animal model and in man by the fact that if these cells are absent or are defective in their function, it's clear that are involved in the autoimmune disease. Now, since the work that Medawar has done, and again the prize, essentially is clear that in animal model, transplantation tolerance can be achieved. This is just an example of our collaborator, Alberto Sanchez-Fuentes, where it's clear that if you transplant incompatible islet between two strains of mice, and you use a tolerance-inducing protocol, you can see that these islets are maintained forever. But what is also important, and we go back to the regulatory T cells, that if regulatory T cells are depleted from these recipient mice, then the transplant are rejected, implying that regulatory T cells are very important in the maintenance of tolerance. However, all this seminal work essentially has been a lot more difficult to achieve in large animals, and obviously also in man. And the main reason, going back to transplantation, that is the interest of my lab, is that in health you have an equilibrium between effector T cells and regulatory T cells, but in transplantation there is a dominance of effector T cells. And although these cells are kept in check with immunosuppressive drugs, the immunosuppressive drugs are linked to morbidity and mortality. And despite the use of the immunosuppressive drugs, it's clear that half-life of transplant is not more than 10 years. And that is the reason that us and other groups in the world decide that we need to develop strategies to induce essentially transplantation tolerance. And one way forward for everything that I told you so far is to essentially tip the balance in favor of regulation, and by increasing the number of regulatory T cells in transplant patients. And the way that we started more than 10 years ago is thinking that we can expand these regulatory T cells in vitro and then adoptively transfer Tregs in transplant patients. And the idea is to take blood from end-stage patient in need of transplantation, then purify this population from the blood, as I showed you before, and then expand these regulatory T cells numerically, and then inject back in this patient receiving transplant. You can think of a very similar approach in the context of autoimmune disease. And took us, as I mentioned, more than 10 years to end up moving a manufacturing protocol from the lab to the GMP facility, and this happened 4 years ago. And essentially what the team in the GMP facility does, take the blood or leukapheresis from this patient, and then the regulatory T cells are enriched by depletion of CD8 and CD25 enrichment. And then, without going into many details, these cells are expanded with stimulation every 12 days. And what we found that rapamycin is a very important drug to maintain the stability and function, but mostly the purity of these cells. And these cells are expanded polyclonally with anti-CD3 and CD28 in the presence of interleukin-2. Then the cells are cryopreserved, and after all the release criteria, the analysis of the purity, the function, and also the sterility, the cells are then injected in patient. And 4 years ago, we started 2 clinical trials, the one study in kidney living donors in dose escalation, very similar to what John presented, and the trial that is liver, disease donor, and again in dose escalation. And I want to stress here the importance of the GMP team that is in the tower of the Guy's campus, that without their involvement and their commitment, I think we couldn't achieve what we achieve today. Starting with the description of the one study, this is a sort of publicity, how important are these EU consortium, and I hope that we can continue with this after the Brexit. But essentially, there are 6 centers in Europe and 2 centers in the States. Everything is coordinated by Regensburg and Gisler. And there are also 2 companies. Oops. Should I answer?
It's a little early for a question, just tell them to wait.
Hello? Somebody there. Probably was, anyway, I don't want to say. And then Milteni and Beckman, as I would say, are the industry involved in this, and Ed Geisler is coordinating all this. And what I want to show you is our UK experience, Oxford and London working together to manufacture and also to inject the Tregs in patients. Now, the clinical trials got 2 arms, a reference arm where the patients are treated with combined therapy of steroids, MMF, and tacrolimus, and then at the time of transplant, they receive bacilliximab or anti-CD25 antibody. And this is the reference arm that is very important, as you will see later on in the analysis of the immunological response of this patient. Then the cell therapy arm with the same combined therapy, but this time, instead of bacilliximab, the patient receives regulatory T cell polyclonally, as I showed you before. And optional is the withdrawal of MMF after 9-12 months from the start from the transplant. We are the first in the consortium, actually already 1 year ago, that we completed this clinical trial. We treated 12 patients with 4 different doses from 1 million per kilogram up to 10 million per kilogram. And the good news for us is that we can say that the regulatory T cells are safe. And this is based on the renal function of all these patients that following the transplant and the treatment with the cell therapy, essentially they all have a very stable creatinine level. And what we are waiting now for is the results of the immunomonitoring. As I mentioned to you, this will be by comparing the results of the immune system and all the parameters from the reference group with the cell therapy group that will give us an idea whether, apart from the safety of the treatment, whether these regulatory T cells had any impact on the immune response of this individual. Now, moving to the liver, the trial, this was one single arm, and some difference. We use ATG depletion therapy at the start, at the beginning of, at the time of the transplant, and then the patient were treated with tacrolimus and then combined with sirolimus or rapamycin. And then the regulatory T cells were injected when the immune system, following the depletion of ATG, start to be reconstituted. And the plan also here was to do a dose escalation, and unfortunately, Because of the condition of the patient that had many alterations waiting for the transplant, and also that had some problem post-transplant, after long effort, we were able to treat only 3 patients with the lowest dose. And this is the reason that in discussion with the MHRA and also with the funding body, the MRC, we then decided to change the pool of the patient, and we select a patient between 6 and 12 months post-transplant when the clinical state was stable. We didn't use ATG, but we, again, used this combined therapy, the sirolimus and tacrolimus. And the cells were then injected, again, around after 3 months, and the 2 doses left, 4.5 and 6. And although here I put the 4 patients, this morning I received the good news that the 5th patient has been treated, and all the patients, the 3 previously dosed, and these 5 patients, they are all fine. That means we can conclude from this initial work with polyclonal Tregs that the adoptive transfer of polyclonal Tregs is safe, and has been altogether a success. I mean, obviously, I haven't told you all the difficulties and how long it took us to reach this point, but at least we can say that the cells are safe. And the question now is this really the end or the beginning of a new area? And I think that this is just the beginning. And this is very much based on the work that we've done in preclinical model in the lab, where we have evidence that donor-specific Tregs, namely Tregs that are expanded to be specific for the transplant, are superior compared to polyclonal Tregs in inducing transplantation tolerance. And the question is why you haven't started with that. And the main reason is because the approach that we used before with the Clinimax doesn't provide the purity of the regulatory T cells that we felt safe in the generation of donor-specific Tregs. But now we have in the GMP facility a cell sorter, this Titomax, that will allow us to generate Tregs with specificity for the graft. And I would like to spend the last few minutes linking back to what John presented. In the last year and a half, we changed the way that we generated these donor-specific regulatory T cells by using and borrowing the idea from the cancer field. Namely, we decided to use the methodology, the chimeric antigen receptor, particularly to target the regulatory T cells to the HLA class 1 that is always expressed in the graft. And with a huge help from John, we generated to construct the CAR and the truncated CAR that John described before. And the regulatory T cells were transduced with these 2 constructs. And the first thing that Dominique did in the lab, he checked that the transduction with CAR didn't modify the phenotype and also the function of these regulatory T cells. So if you just focus on the CD25, that is one of the markers, as I mentioned, for Tregs, you can see that the expression between untransduced and transduced CAR is very similar. And then Dominique, after demonstrating that in a polyclonal manner, these regulatory T cells were very similar in suppressing the responder T cells, then addressed the relevance of the expression of the CAR, whether these regulatory T cells expressing the CAR for HLA-A2 were superior in inhibiting the responder T cells when an antigen-presenting cells expressing the relevant antigen was present. And while for the untransduced Tregs, you can see that there is no difference if the responder T cells were stimulated with an A2 positive or an A2 negative antigen-presenting cells, it's clear that when the Tregs express the CAR specific for A2, they have an advantage in inhibiting the responder cells. Not much difference was observed for the delta CAR. And lastly, we move in vivo. This is a humanized mouse model that we have very well established in the lab. And what Domenico did, they transplanted human skin from an HLA2 individuals in immunodeficient mice, and while this skin was embedding in this animal, it generated from an A2 negative individuals the regulatory T cells, either polyclonally or expressed in the CAR or the delta CAR. And then after 4 weeks, this animal was injected either with the peripheral blood from the A2 negative individuals, plus or minus the regulatory T cells that were generated. And then different parameters of skin pathology were evaluated, and this is one of these parameters, the Ki-67, that represent the proliferation of the keratinocytes. And you can see here this line green represents the proliferation of the keratinocytes when the mice that were expressing this human skin were injected with PBMC only, is very clear. And when the mice were injected with PBMC in the presence of the polyclonal Tregs, this proliferation was only in part decreased, and was completely decreased, as you can see here, in the presence of the CAR Tregs, but also in the presence of the delta CAR. And this is quantified here. And you can see that for both the CAR and the delta CAR, essentially the level of Ki-67 proliferation was very similar to the mice that received just saline. And one of the interpretations for these results is, in these slides, shown by the accumulation of the regulatory T cells in the skin. As you remember, I mentioned that one of the markers is FOXP3 that is expressed by the regulatory T cells. And if you just focus on the cumulative data, it's clear that when the mice were injected with the PBMC together with the regulatory T cells, there is an accumulation of the Tregs, and this is even more when the regulatory T cells express the right CAR. Not much difference between the CAR and the delta CAR, and this is possibly explained by the fact that localization of these regulatory T cells expressing the right receptor was enough to inhibit the pathology of the skin. Now, in conclusion, I think that the CAR, I hope I show you that the CAR-mediated recognition of class 1 donor antigen offer an advantage compared to polyclonal Tregs, but also something that I think is very important, that CAR expressing Tregs offer also the possibility of further manipulating these cells, and essentially to allow the increase in survival and potency of these cells in vivo. And altogether, and also based on published work in the field of graft versus host disease and type 1 diabetes, I think that Treg therapy and in the field of transplantation, donor-specific Tregs really holds a promise for promoting clinical transplantation tolerance. And I just want to finish by thanking all the people involved. This is just a short list about the collaborator, the people in the GMP facility, and these are some of the key players in the lab. And then I want to also acknowledge here Robert. We started probably this journey nearly 20 years ago, and now finally we move everything from the bench to the bedside. And then I want to thank also the grant body, BHF, that really provide support in all these years, particularly in the preclinical work, and MRC and the rest for supporting also the clinical trial. Thank you very much for your attention.
Giovanna, terrific. Thank you very much. Questions? William at the back.
William Alazawi, Queen Mary. Thank you very much for that great talk, and I think it's a really exciting area. In liver transplantation, as you know, disease recurrence is quite an important feature and something we look out for after transplantation. You probably haven't got enough efficacy data yet, but do you think disease etiology going into transplantation is going to affect whether or not you can select a particular patient for Treg therapy? Or do you think this is just a matter of controlling the reaction to the graft?
I mean, that, yes, is the point that I tried to stress at the end. I mean, the reason that we are trying now to generate donor-specific regulatory T cells is because we want that the regulatory T cells are really targeting the graft and managing to control just the response to the transplanted tissue. However, the recurrence depends very much on what. I mean, if it's, for example, a viral issue, you want to say something else?
No, I was just going to say, I'm particularly thinking of the immune-mediated, so autoimmune PBC, PSC.
Yeah. Yes, I don't know how this can fit here, but I mean, essentially, if you inject the regulatory T cells, I suppose you can, you can manipulate these regulatory T cells. It depends on the original disease, and that is where the CAR can help very much, or the genetically modified Tregs can help. I thought you were mentioning mostly about the viral hepatitis, where obviously if you do donor-specific, probably the big advantage is that the target will be just the alloantigen.
Jerry.
So, Jerry Brown from UCL. My question is fairly similar to that viral question, which is that the corollary to suppressing autoimmunity and transplant rejection is that you might open the patient up to infection. This is another immune-modulating disease that will increase the risk of infection. Do you have any data or evidence? We
got data in the one study, and that again are polyclonal Tregs, where obviously the concern that we have that if we see some infection with the polyclonal, we hope that we don't see with the donor-specific. However, in the one study, essentially comparing the reference group with the cell therapy group, we saw less infection rate in the cell therapy compared to the reference. But these, again, are only 12 patients. We are waiting for the other group to join us in see whether this is still valid.
Mike.
Mike Aronstein, UCL. Great talk, Giovanna. I wanted to ask you about migration and whether you think that the Tregs are preventing effector cells from coming in or controlling them there. Do you have any data about that?
Yes, we actually, again, John presented the very nice rotating mouse. We are doing very similar work with our regulatory T cells. We have these regulatory T cells expressing NIS, that is the pump, that allowed then a different time point longitudinally to see where the Tregs go. And essentially, in this humanized mouse that I just shown, depends very much whether, and somebody, I think you mentioned, whether the macrophage are present or not, mouse-derived. We see a very different migration, but we see just in the skin. We see either very early, if the macrophages are present, or late at 30 days, that is the time that actually we sacrifice the animal to look at the histology. We see a very clear signal in the skin, in the target organ. Obviously, these mice do not have a lymph node. That means we don't know, we cannot address this question in this model, but we are hoping to do in a real mouse.
Thank you. Colin.
So, Colin Down from Cardiff. Giovanna over here.
Ah, sorry.
Thank you. It was very, very nice. So just to go a bit further on this issue of risk, we've heard, 20 years later, Bobby's sorted his risk out. But so two things, really. One is, as I understand rightly, there are only 60% FOXP3 positive of what you put in. So why don't you generate effector cells? And the other issue is, tumors like Tregs. They love it because it allows them to grow. So is there a malignant risk here?
Yeah. I don't have an answer, but obviously one of the reasons that we are so fixated with the donor-specific is to avoid all these problems. What I can tell you that, again, 12 patients is not very much, but the last patient was treated in the one study 1 year ago. And actually, all these 12 patients, not only they have a normal level of creatinine, but also none of these had any biopsy-proven acute rejection, namely that whether this doesn't address your question, but address the fact that probably there is efficacy, but these patients, so far, they haven't shown any adverse effect. But I mean, it's very early, it's only 1 year. No sign, but again, it's very early.
Tony.
So I'm also concerned that the induction of tolerance will allow the emergence of malignant clones. And how are you going to protect against that.
Yeah. I mean, again, we are not the first one to use regulatory T cells. As I mentioned, in graft versus host disease, Blazer in the States and Diani in Perugia published this. And this patient now, they've been with regulatory T cells. Again, I don't know how long they will last for many years, and there are not malignancy there. In our case, as I mentioned again, we want to move to donor-specific regulatory T cells exactly for this reason. We wanted that the regulatory T cells just are targeting the organ and they are not distracted by other inflammatory conditions. And I think by targeting this, I mean, there is also evidence that we can have these cells localized in the organ, and I think this, in theory, should avoid the disseminated tolerance and the risk of malignancy.
Can I ask the final question, if I may? So I'm no immunologist, but what's the chance of inducing tolerance 6 or 12 months after you put a liver in, compared with at the time of transplantation?
Actually, the best, this is a very good question. The best person to answer this is Alberto Sancefuello. He's done a lot of withdrawal of drug from the liver transplant patient, and it's clear that for some of these patients, something happened. They become more susceptible to tolerance time from the transplant. They means
That's in years, isn't it?
Yeah.
It's years, not short.
That means what we are hoping is just to, by using Tregs, to shorten this length of time and increase the pool of tolerant patients.
Great. Thank you very much.
Thank you.